Uh, Sincere apologies for all the confusion. I mean, I think there's always there to learn. So I'll be covering about intumescent cataracts, and it's just a series of videos that I have. And this is basically, I always believe in creating a small neck and then subsequently removing whatever cortical matter. If it flows out, it's fine. Otherwise, you just remove that and then inject a dispersive viscoelastic on top of the capsule, intact capsule. And as you can see, the whole procedure proceeds in a very methodical manner. And especially when it's flocculent cortex, it might be necessary to do multiple aspiration of the cortical material. It's always extremely important to make sure that we are not injecting the viscoelastic into the capsular bag because that itself might cause a runaway. Most of these intumescent cataracts are associated with a brittle nucleus. So actually removal of the nucleus is not really a challenge. And just in case you get a smaller rhexis like this, I always remove the anterior capsule so that there's no capsular phimosis. One other thing that we could do is also to create small nicks in this rhexis margin so that the tendency for rhexis phimosis is not there. The cartoon here is extremely important. While you watch the video, basically the idea is to keep the intracameral pressure higher than the intralenticular pressure so that you have a flat anterior capsular surface. That's the reason we aspirate liquid lens material from the capsular bag or keep injecting viscoelastics as I'm going to be doing now so that you have a flat anterior capsule. The moment this relationship is disturbed and the capsule moves forward, there's a tendency for the rhexis to run off into the periphery. And essentially, the successful rhexis in these situations entirely depends upon balancing these two forces of retaining the intracameral pressure higher than the intralenticular pressure, whatever be the measures that you adapt. As you can see over here, there are multiple aspirations that are being conducted, and each time the viscoelastic is being injected, the intracameral pressure is increased, then subsequently in a very methodical manner, initially started out with a 26 gauge needle, now subtractive forceps that you use. I would like to concentrate on this particular step. It's taking a while, losing my patience. This viscoelastic is running over here, but I try to complete the rhexis, and that's exactly when should not have been done. I should have refilled with the viscoelastic. So you can see right at the very end, I get a rhexis runoff simply because there was viscoelastic which was leaking out. I did not care to refill the anterior chamber. Of course, managed to do the case without the wraparound of the rhexis and then implanted a lens. Suffice it to say that as far as you're able to keep the intracameral pressure more than the intralenticular pressure, whatever be the means you employ, then the situation is well under control. Pediatric cataracts is another situation, and especially if it's combined with a intumescent cataract like this, then it's a double challenge in the sense that you have to deal with a very elastic capsule. At the same time, the capsule is bulging forward. And in these cases, you always aim at a much smaller rhexis than what you want. Usually, I aim at around a 4 to 4.5 millimeter rhexis. End up getting around a 5.5 millimeter rhexis. In case a posterior capsular rhexis becomes necessary, that should be within the confines of the anterior capsular rhexis. And as you can see, I'm grasping, re-grasping, proceeding in a very methodical manner. Even if it's not an intumescent cataract like this, it's a good idea to stain all these capsules simply because it reduces the amount of elasticity and gives you a little better control. I believe in these pediatric cataracts, once you get an adequate rhexis, then 75% of the surgery is over. As you can see over here, removing the fairly liquid cortical material is no challenge. And subsequently, you can go ahead with the rest of the surgery. In case you have a situation where there is a bit of a rhexis runoff, in spite of all the maneuvers that you have taken, as you can see over here, I'm proceeding with the creation of the capsular rhexis. But as I come here, there is a certain amount of a tendency for the rhexis to run off towards the periphery. And I correctly go back and aspirate a certain amount of lenticular material and then refill the anterior chamber with the dispersive viscoelastic. That's then go back Right now, you please watch at this point, there is a tendency for the rhexis to run off into the periphery. And this is exactly where you have to be extremely careful. And instead of going around in a curvilinear fashion like this, it's trying to extend like this. In this situation, the normal tendency would be to re-grasp and drag it like this. What has been described by Brian Little, and I find it always helps, is to go back here. Let me just take you through that step once more, even if it takes a little while, because I think this is a very important step. And that's aspiration of the lenticular material, the tendency for the rhexis to run off. And I really grasp the rhexis margin over here, drag it in this direction, in the direction in which I was creating the rhexis, drag it towards the center and the apex, and that gives you a hold over the rhexis and once again brings it back into position, and then you are able to proceed with the rhexis in the planned manner. You can see I'm dragging it back towards the apex of the cornea and towards centrally, and then I'm able to get a control over the rhexis and proceed in a more methodical manner. As I said, the injection of the sometimes it's a good idea to even use a cohesive viscoelastic because that flattens out the anterior capsule even better than a dispersive viscoelastic. Maybe this is the only situation where I would recommend a cohesive viscoelastic. As you can see here, subsequent to the intraocular lens implantation, you can see there has been a tendency for it to run away, but it has been brought back by this by our brand little maneuver of pulling it back, pulling it centrally and towards the apex. And in case you have a situation like this, where it's a Morgagnin cataract and you are, it's not only the anterior capsule, even the posterior capsule is very tremulous, and there is a tendency for it to trample in. Obviously, the lenticular material flows out. You create an adequate capsular rhexis, usually about 4.5 millimeters. And here I'm bringing out the entire hard nucleus into the anterior chamber. And because the patient was one-eyed, had already lost the other eye, did not want to risk the posterior capsule, any risk to it. So I go ahead and implant the intraocular lens, and it's again a brittle cataract. And using the right phacoemulsification parameters, doing the phacoemulsification as posteriorly as possible. Of course, there would be a certain amount of loss of endothelial cells, but then as you could maybe visualize in the end, I used a 2.8 millimeter sleeve and completed the phacoemulsification with the intraocular lens acting as a scaffold. In case you have access to digital marking devices, that's again a great way to go. As you can see here, I have a 5.8 millimeter, I want a 5.5 millimeter rhexis, but I adjust my capsular rhexis at 5.8 millimeters. The idea is to run the rhexis within the confines of this capsular rhexis, the digital marking device that I have. That essentially is a great device. Using a simple 5 millimeter marking on the cornea and then using it as a control is also a good idea, and that also works very well. Now, coming on to white cataracts and usage of laser, as you can see over here, it's an intumescent cataract. You can see it bulging forward. Maybe this is the most important indication and use for a laser cataract surgery and the creation of capsular rhexis in a situation like this. As you can see, it's a free-floating rhexis that you have over here. And basically, I don't even have to do anything with it. I just go in with the phaco probe and the rhexis just flows in. It's not always the situation like this. In a situation like this, where you have the, again, an intumescent cataract, as you can see over here, we are going to end up with a disrupted capsule over here, and everything seems to be under control. Only when I stained the capsule, I realized that basically because the gush of fluid from the confines of the capsular bag, even in spite of the availability of a laser platform, there is a disruption of the capsule, and I had to go back and create a complete the intraocular lens implantation. In this case, the situation is slightly different. You can see that it's again an intumescent cataract, and there is a certain amount of capsular fibrosis that is also there. I'm able to create the rhexis, but then when I stain the capsule, I realized that it's not a completely free-floating rhexis. As you can see over here, there are shreds of capsule over here, and that you have to be cognizant of the fact that this could sometimes happen. Mind you, this is selection of a few cases. Most often, when you use a laser platform on these intumescent cataract, you get away with a very nice rhexis being formed. But you must be aware of the fact that sometimes you can get a situation like this. But again, you have a template to go ahead and create the complete the rhexis. You have just to got to be careful, recognize this, and then go ahead and complete the rhexis in a methodical manner. As you can see, there are a couple of places where it has run off, not into the periphery, but up to the rhexis margin. What I essentially do is to exactly do the maneuvers that we are used to doing while creating the rhexis and completing the rhexis in this manner. And then subsequently, of course, surgery is quite routine. Last of my slides, and as you can see over here, when you essentially have a grid pattern, you may not visualize a situation like this where the rhexis is not complete, but you have to be aware of this fact. And then essentially what I do is to wrap around that area where the rhexis is not complete. And you can see the small dent over here that's been created. That's because I was aware of the fact that rhexis is not complete over there. And with the Utrata forceps, I generally went around that and completed the rhexis. It's important that you are aware of these facts in spite of the fact that you might have a laser platform available to you.